I wanted to talk a little bit about TIM-3 because it's a fairly unique target in MDS. Not only is it widely expressed in cells of both the innate and adaptive immune system, so while it's co-expressed with PD-1 on dysfunctional T cells, one of the things that really distinguishes it from PD-1 is that it has broad expression on myeloid cells, including monocytes, natural killer cells, and most importantly, is also expressed on leukemic stem cells and leukemic blasts, but not on the normal hematopoietic stem cells, which makes it a really attractive target in MDS and AML. The antibody that we are studying in our presentation is MBG453. It's a high affinity humanized anti-TIM-3 monoclonal antibody, and it enhances immune-mediated cell killing of AML cells in vitro. And the hypothesis is that MBG not only simultaneously targets immune effector cells, but also leukemic stem cells and blasts. This is the reason we set out to first test MBG in high-risk MDS and AML. I'm going to go a little bit into the details of our study. The study that we're presenting is a phase 1b study looking at MBG453, our monoclonal TIM-3 antibody, in combination with HMA in both MDS and AML. Our study, we enrolled up to 207 adult patients, and we had 3 different cohorts. We were looking at IPSS-R high or very high-risk MDS patients, unfit newly diagnosed AML patients that were ineligible for standard chemotherapy, as well as relapsed refractory AML patients ineligible for standard chemotherapy. The study looked at a variety of different combinations, including MBG in combination with decitabine as well as azacitidine. The decitabine arm started back in 2017, in August of 2017, whereas the azacitidine arm started enrolling fairly recently in February of 2019. We looked at MBG in different doses and in different schedules. So MBG was given on day 8 and day 22 at doses of 240 milligrams every 2 weeks and 400 milligrams every 2 weeks. It was also given all on day 8, which is Q4 weeks, at a dose of 800 milligrams. And I'll talk about in a little bit why those doses and intervals were chosen. Our primary endpoints looked at maximum tolerated dose and recommended phase 2 dose. We also looked at safety, tolerability, and our secondary endpoints, we wanted to look at preliminary efficacy of this combination. Of note, this study did have additional arms looking at MBG453 as a single agent, and also in combination with Sabatolimab, which is an anti-PD-1 antibody. These arms did not move forward due to lack of efficacy, as well as some additional toxicity in combination with the anti-PD-1 antibody. So our patient characteristics were, as you would expect, our high-risk MDS cohort enrolled patients who were either high or very high risk by IPSS-R category. The median age was over 70. Our newly diagnosed AML cohort enrolled mostly adverse risk cytogenetic patients, about 50%, with the median age also of over 70. So to summarize the results of our phase 1b study looking at combinations of HMA, both decitabine and azacitidine with MBG453, in our high-risk MDS group, and that's what I'm going to focus on today, in our high-risk MDS group, we saw that both these combinations were extremely well tolerated, with a median exposure of about 8 months in the high-risk MDS arm and about 6 months in the newly diagnosed AML arm for the decitabine combination. The exposure time is less in the azacitidine combination, as a study opened fairly recently. In terms of response rates, we see that patients with high-risk MDS had an overall response rate of about 62% in the combination with decitabine, and about 58% in the combination with azacitidine. We also saw that these responses appear to be durable, with patients that have achieved a CR continuing on therapy for, in some cases, longer than 1.5 to 2 years. We saw several cases where patients then proceeded to stem cell transplant, which is always something we look for. And in terms of the treatment-related AEs, we saw that the majority of the treatment-related AEs included the ones that you would see with HMA alone. So for example, febrile neutropenia, thrombocytopenia, anemia. And when we tried to look specifically at immune-related AEs, given the mechanism of action of MBG453, we were relieved to see that a majority of the immune-related AEs were grade 1 and 2. And these included some AST/ALT abnormalities, some thyroid function abnormalities, and some skin rashes. There were very few grade 3 immune-related AEs related to the study treatment specifically. There were no grade 4 or 5 immune-related events, which was very reassuring. And lastly, in terms of patients that came off study due to adverse events, we had only 4 patients, so about 2% of our entire study population that actually stopped therapy because of adverse events related to MBG453. So in summary, we felt that this combination of MBG453 with azacitidine or decitabine is well tolerated in patients with high-risk MDS and AML. We had very few treatment-related AEs, specifically immune-related AEs. Most of them were low grade. This combination appears to show some promising anti-leukemic activity in high-risk MDS patients. The overall response rate of about 61% with decitabine and 57% with azacitidine. The median onset of response is about 2 months, and there's emerging durability that's being seen in this population with a median of about 8 months in terms of the treatment combination with decitabine. So these combination studies are moving forward. There's a phase 2 as well as phase 3 studies planned, both in MDS and AML in the future.